Thank you for everyone to come today. My name is Vikram, one of the neurosurgery residents. Talking about the neuro exam today and the basics of it, and at the end of it we'll talk about some of the red flags and when we as neurosurgery people get really nervous, and before we run, you guys should definitely give us a call about what's going on with the patient. So the neuro exam, these are the general components of it. You can go into a lot of depth with it, but there's always a mental status exam. You talk to them, see if their language is intact, their cranial nerves, coordination, motor, sensory, and their reflexes. Of course, if you do all these thoroughly, it's like a 30-minute exam, so we always do it in a kind of a bridge, grossly speaking kind of version. So mental status, this always starts with, for me at least, when I walk into the room, I see if they're alert, if they're sleeping, if they're stuporous, if they're snoring, if they're easily arousable. A really basic and transmittable way to communicate this is GCS. So whenever I talk to anyone, I always give them a GCS. 15 is the best case scenario, 3 is the worst case scenario, and somewhere around 8 is when you should consider intubating the patient. And you can all look this up, but it's a very important measure of someone's capacity to think and take care of themselves from a neurological standpoint. Language, this one's a little bit more tricky, especially if English is a second language. There are a couple of aphasias we can talk about. There's the Broca's and Wernicke's aphasias. A Wernicke is considered a fluent aphasia. They just talk. It seems like language, but it's not actually language. I've got some videos, hopefully it'll work.
Hi Byron, how are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment, talk with the people over there. They're guiding for them at the moment. They'll save at the moment. He'll water for him. With luck for him.
So we're on a cruise and we're about to
We
get
will
to the
start
shore.
right here and they'll save their hands right there for them.
And what were we?
So you can see it looks like he's producing language, but it's gibberish. He doesn't know he's producing gibberish. He doesn't know what's going on in the world. Really the big times where we see just Wernicke's aphasia is probably surgical or tumor, where we're working near Wernicke's area and we mess with it. In strokes, usually you get both Wernicke's and Broca's aphasia, so a global aphasia, because both of those areas are supplied by the same big blood vessel. So if you lose one, you typically lose the other two. Here's Broca's.
Tell us your name.
Mike Caputo.
And Mike, when was your stroke?
I was 7 years ago,
Okay.
and
And what did you used to do?
worked Autodesk, seven sales, and worldwide, and very good. Yeah,
Okay. And who are you looking at over there? When you turn your
that's
head.
my wife.
Okay. And why is she helping you to talk?
She's a speech.
So you have trouble with your speech?
Yeah.
So you can see that he can make sense of the world, he's able to understand, but he has a really hard time producing language. So these patients get really frustrated, and a lot of them get depressed because they can't communicate to the world. They're almost like locked in a sense, from their language. To test language, you can always talk to them, see how they're doing. If there's any sense of it, if you're concerned about it, you can always ask them to follow instructions. So I always go with the basics, like show me a thumbs up, wiggle your toes, give me a number 2, peace sign. And when you do that, I never show them any of the actions themselves, because if you show them the action, and if they do the action, you don't know if they're following commands or if they're mimicking. So I just completely stoic, I just say like, show me your teeth, give me a thumbs up, and if they do it, I know they're following, they can understand and carry out actions. If they don't do that, then I give them a thumbs up or something and see if they can do it. then that's mimicking to me.
Just doing it, yeah. And what's that called?
These are all the cranial nerves. We don't test all of them every day. The big ones that we pretty commonly test are extraocular movements, which is 3, 4, and 6. If you just do like an H, you can test all of them to see if there's palsies in any direction. If you do find a palsy, we don't expect you guys to know if it's 3, 4, or 6. Just say that they can't move laterally, they can't move medially, they can't move superiorly or inferiorly or something like that, and then we can localize later on. Optic nerve is a really common and useful one. That's the pupillar response. So if you shine a light in someone's eyes, it constricts in response, and if you take the light away, it'll dilate again. That one's really big in terms of determining ICPs, or intracranial pressures in the head. So that's when we test whenever we're concerned for an intracranial process, or ICPs. And another easy one is facial. You just tell them, when we didn't have masks, I would just say, show me your teeth, or smile, and they would show it to me. Now I tell them to open their eyes real big or close their eyes real tight. If it looks symmetric, I know facial's good. And these are all of them, what they do. And these are some of the reflexes we were talking about. So pupillar response. So this is called anisocoria, or unequal pupils. If a patient is asleep and they have this, really bad sign. That means they're starting to herniate their brain usually. So their uncus, or the medial part of their temporal lobe, is so swelled it's pushing on the brainstem, and it's crushing the brainstem, and that's why the brainstem can send out this autonomic response correctly, and that's why the pupil becomes dilated or sluggish. So that usually means they're starting to die, or they might be dead if it's totally blown. So this is what a blown pupil looks like. Corneals, not commonly tested. In sedated, intubated patients, we test it. We just touch their cornea, and if they blink, we know it's intact. Gag, you can do it with a yanker. Cough, you can do it with coughing, what's it called? You know that tube that goes through the inline suction? Yeah, you can test cough that way and gag with the yanker. Coordination, this is more about cerebellar dysfunction or function. Just some simple things you can test to see how you're doing. Sensory, it tells us about 2 parts really. It tells us about the spinal cord and also the sensory component of the brain. Sensory and motor are right next to each other in the brain, so it's really weird to just get sensory loss without motor if it's a stroke, because it gets supplied by the same blood vessels. If it is one or the other, it's usually because there's a mass effect or something pushing on one that hasn't gotten to the other side yet. So if that mass or tumor or whatever were to progress, if you had motor, you'd probably get sensory. If you had sensory, you probably will get motor later on. The 2 columns here, it's not interesting, but there's 2 different ways you can move sensory information up and down. Motor, this is probably what everyone tests every day, seeing if they're full strength or not, and this is the grading system. To me, 3 is the big difference here, if they can move against gravity or not. 4 and 5 is actually very tough to test in post-surgical patients, as I'm sure you all know, because whenever they move, they're like, my back, my neck, something hurts. And it's tough. I always, when they say it's pain limited, I just say, like, give me one good flash, like, give me all you got for just a second. And if I feel like they're full strength for that 1 second, then I think they're full strength. But if they are consistently not full strength and they can't do it, then I'd say that's a 4 or 3 or something less than a 5. A really nuanced way of testing motor strength is called perineal drift. You put your hands out like this. I say pretend like you're holding a box. Close your eyes, and if you don't have visual feedback into strength, if you have some kind of weakness, you start drifting your hand like this, and people don't know it. So it's a really subtle sign to test if you have weakness. these are all the contributions to the muscle groups up here. Reflexes, they're plus or minus. A lot of people here have neuropathy, so reflexes aren't as brisk here. And it's also, it can go both ways, but this is generally some of the reflexes we test. This is probably the most important slide here. Red flags. How do you know when something bad is going on or not? So the big thing here is that something new has happened. It's a new onset weakness that's not pain limited. So if someone was full strength, an hour ago and now they're 3s or 2s, or all you can see is like muscle contraction, definitely give us a call. We probably need to get like stat imaging to figure out what's going on. New numbness in a dermatomal distribution. So if we're working around L4, L5, and there's L4 or L5 numbness, then it's probably because of us. Our hardware might be in the wrong place, we might be crushing one of the nerve roots, and that could be surgical. New onset sleepiness that's not medication induced. So I know a lot of our patients here, their threshold for pain is very low, and they just want to be like intubated to stop the pain. It's just tough. It makes things hard for us as medical people. So if you can't attribute it to any kind of like a bolus of fentanyl or Dilaudid or like Prope or something like that, please let us know, especially if it's involving the brain, because at that point we don't know if the pain medication is causing the sleepiness or it is high intracranial pressures. Because when the pressure in your brain gets high, people get sleepy and they can die that way. New onset nausea, vomiting, along with high ICPs, there's irritation of parts of the brain that have controlled nausea, vomiting. So it's commonly explosive nausea, vomiting that shoots out. That's a sign of high ICPs. And then Cushing's triad, another sign of high ICPs. It's bradycardia, hypertension, and autonomic dysfunction. It's essentially the brainstem trying to get as much blood to the brain as possible, because that pressure in the head is so high that the heart can't pump blood up there. So it's trying its best, and that's how it represents itself. And sluggish pupils, as we were talking about, it's that brainstem being compressed, and it can't send the signal out to the eye to dilate or constrict properly. So if there's any sluggish pupils or anisocoria or anything along that line, please let us know. We have to get a stat head CT. And then unequal pupils, same thing. I think that's all I got. Any questions on that? I know it's tricky. Neuro patients, everything gets graded by pain medication, and it's tough. If there's any concern at all, let us know. We'd rather know about it than not know about it. But yeah, it's a tricky exam.
Thank you.
Thank you very much, guys.
Is that